Hello, and a very, very good evening to all the viewers of this webinar through our Chess Council of India webinar series. Today is a very, very special day in India. We celebrate it as Teachers' Day in memory of late President Sir Sarvapalli Radhakrishnan. It is told that Guru Govind dou khade, काके लागू पाए, बलिहारु गुरु आपने गोविंद दिया बताए. Well, teachers in medical profession and for every domain, teachers are something which are very special to everybody. But in medical profession, our teachers are everything for us. I think the whole life is dedicated more of copying our teachers, becoming like our teachers, and emulating those teachers. So CCI always tries to bring knowledge first, and with this concept of Guru Var Guru Ke Saath, which started few years back, every Thursday this webinar has become a source of that Guru Gyan or knowledge that we all consider to be very first at CCI. On this Teachers' Day, I would like to give a lot of thanks to our respected Krishna sir, CVK sir, Atri bhai, our Narayana sir, the whole team, Shivani ma'am, who is there at the back of all of these webinars which are brought every Thursday. And today is a very special day indeed. Well, this year's theme is empowering educators for a sustainable future. So that is why coincidentally, or let's say कायनात ने ये सारे सितारे मिलाए हैं कि today we have 4 very eminent professors as part of today's panel. Respected Professor Radha Munje ma'am, we have respected Dr. Salil Bhargava sir, we have Professor Dr. Animesh Jain sir, and we have Professor Dr. P S Shajahan sir. And though not in academia that way, but no less than professors Dr. Vibhu Kawatra and Dr. Indu Bubna. So without taking up a lot of time and giving a lot of thanks and respect to our respected panelists, our teachers, and a big thanks to all of you on Teachers' Day, because believe me, in CCI, we really revere our teachers, and here it's one for all and all for one. So we see that even the youngest of young in the chess field teaches quite a lot to us day in, day out in the discussions which happen on the CCI groups. So I would like to hand it over to respected Professor Radha Munje ma'am for today's very important and relevant discussion, with the hope that all of us at CCI continue nurturing knowledge and continue respecting our beloved teachers. Thank you very much.
Thank you, Dr. Ravi Doshi, for starting today's webinar on a wonderful note, where we pay our humble respect to all our teachers. But I believe everyone around us is a teacher in each capacity. They teach us something and we learn something from them. So, good evening, all panelists, members of CCI, as well as the audience who have logged in. Welcome to this webinar, which I should be terming as it's different. It's a different type of webinar, and I'm sure it will touch a chord in each one of you. This is a topic which is near and dear to all of us, which is so much relevant कि इसके लिए मैं कहूंगी आज भी है और कल भी रहेगा. It's an important topic. And I think Dr. Krishna and the whole team of CCI wants each one of us to be aware and be prepared for what we are going to talk about today. It's code violet. And I'm sure that in the color violet, there is some dark colors which are blackish. You also added, but it also has a brighter shade if you add a pink color to it. So even if the topic is, has different shades, I'm sure by the end of the webinar, we would have a good insight and a positive approach towards whichever incidences we come across and which falls under this code violet. We all know that code violet is an hospital emergency code. But because we have wonderful speakers with us, I'm not going to tell you right now what is code violet. We are happy to have 2 wonderful speakers with us. One is Dr. Animesh Jain, who is a professor at Mangaluru, who would be speaking on concept of various codes in the hospital. And The second talk is by none other than Dr. Vibhu Kawatra, who happens to be, today only I learned he has lot of feathers in his cap and he aspires to get few more also. He's a pulmonologist, he's a pediatrician, he's a trained internist, he's a lawyer, and he has a lot of other trainings and certificates with him. So let's hear from our own um, panelists who are first going to give a presentation. First is Dr. Animesh Jain, followed by that Dr. Vibhu will be talking, and I'm sure each of these talks are different and would give a wonderful perspective of Code Violet. So please, Dr. Animesh, go ahead.
Thank you very much, CCI, and also to Radha ma'am for giving me this opportunity. And thank you, Radha ma'am, for that generous introduction. I will quickly take you through the code violet and how exactly it works, just to give you a brief idea and the summary about this particular aspect of it. So, welcome to the webinar and let's move on. So, I'll just take you through this. So, we all know that the violence among the health workers against the health workers is increasing. And the WHO says that 8 to 38% of the health workers have suffered of physical violence in some point in time in their career. And closer home in India, the Indian Medical Association says that 75% of the doctors, that's 3/4 of them, have faced some kind of violence. So that's quite a large number of people. We know that there are different codes. Code blue is usually used for a medical emergency in a hospital setting or in a healthcare setting. Code pink, though we don't really come across it much, but it has been there for any kind of abduction or kidnapping of the child or infant. And code red is for the fire. Code yellow has been there for the disaster, whether it's an internal or external disaster. External disaster can include floods, earthquake, any kind of transport accident, or any other kind of civil unrest which happens outside the facility. So any of those, as well as internal kind of disasters as well. And comes code violet. Now, code violet usually is reserved for any kind of violent behavior, either emerging from patients or their attenders. So what exactly is this code violet? So this code violet basically is the hospital's response to violent and combative behavior from any kind of people, whether it's the person or their relatives or any other. And this may be posing a threat to the person involved, that is, the healthcare professional or any other, or probably a group of people. Generally, it is used to mean unruly patient, but it also is applied to people who are with the patient. So sometimes there's a mob or relatives and other. Now, how does it work? So usually what is done is when a code violet is activated, there is a message which is relayed or announced on the public address system, the PA system of the hospital, and they mention exactly what is the location. So say third floor, ward 4B, or so say 3B, or this particular ward there. So it will be, or in the casualty on the ground floor. And security immediately responds and provides the assistance, and all the available staff members, the moment there is an announcement of code violet is made, they have to, as soon as possible, reach the scene and form a human chain around the hospital person or personnel who are under threat. And usually a member of staff should try and verbally de-escalate the situation. That means try to calm down, and everybody should have to exercise restraint. Our people that is in the hospital should not, get agitated, angry, or definitely not show any kind of physical violence. Once the situation gets under control, so again, there has to be an announcement made on the PA system, and it should be an all-call announcement, and 3 times it has to be said, code violet clear, code violet clear, code violet clear, so that everybody who hears this is clear that this situation has been handled and it's all right. Let's just quickly go through the code violet standard operating protocol or SOPs. So as soon as there is something like that, as I said, there will be an announcement, but everybody should be able to recognize that there is a potential threat or there is a violent incident probably coming up. And how do we look for that? So we should be able to see and recognize this by any kind of body language change or any kind of raised voice or any physical confrontation happening, any kind of abusive language, any threats issued verbally. All that is indication that probably the situation may go out of hand. So we need to be, everybody should be prepared in the hospital to have these kind of cues. And definitely we have to see that if at all there are weapons, then definitely it's a danger. And the decision making is basically dependent on what the situation is. So if there is an immediate threat to the safety, activate code violet. If there is no surety, it's better to err on the positive or side of caution and seek advice and go ahead with the advice as such. Now, what are these situations which fit for code violet? So any physical assault, any threatening behavior, any verbal threat, any kind of aggressive behavior from the patient or patient party or anybody. The step 2 would be, the moment it is recognized, activate the code violet. And there has to be a swift and coordinated action taken. So the immediate action would be, first thing, call an emergency number. It could be any number which is external or internal or direct line, and report the situation. The person who gets to know that immediately, and then immediately what will happen is they will announce it. So this has to be communicated along with where exactly it's happening, the ward or room number or department or whatever, that exact location, and very briefly to tell what exactly is the situation. So if somebody has come with some kind of weapon, swords or whatever, or even any other, or there has been a physical altercation or something, so that has to be reported. And how many people are there, if you're seeing any immediate danger, so that has to be reported. And the moment this happens, notify the nearby colleagues also as soon as possible, so that they can probably help, as well as they will be soliciting more people to come in. And if that is not probably possible, then move to a safe location and see if it's feasible to close the doors to safeguard yourself and prevent people from entering that area. And then, very importantly, there is a response to code violet when it is objectively activated. So the staff has to look at evacuating. So non-involved patients, visitors, all those people have to be moved away from the incident area. Calm and firm tone has to be used so that people don't panic, and emphasize their safety. Contain this by forming some kind of barrier, so locking, barricade, all that. And physical confrontation has to be avoided. At the same time, communication lines have to be open, security and administration have to be kept in the loop, and at the same time, updates of the evolving situation has to be given. If the person has moved to another area or whatever, so that has to be kept in mind and communicated quickly, so that everybody is aware of that. For the security personnel, immediate responses to arrive at the scene as soon as possible, assess and identify the aggressor, try to de-escalate, and then also clear and non-threatening language to be used. If required, physical intervention may be required. So if verbal is not working, physical restraint has to be done, and make sure that everybody is safe, including the aggressor also is safe. Try and avoid using too much of force as far as possible. With minimal force it should be done. And of course, since this is a situation which demands the involvement of the law enforcement agencies, police and others, so this has to be brought to the notice. It has to be immediately reported. And this situation, if you have restrained them or confined them, so they have to be handed over to the authorities. And administration needs to support this whole thing, monitor the situation from a command center, and coordinate with all the law enforcement agencies, document it properly, including the real-time documentation of the incident as far as possible, of course, or at least factual documentation, whatever action was taken, the timing, any injuries happened. Once this situation is tided over, the incident is over, support has to be given. Reviewing the incident is very important, and implementing further preventive strategies and methods so that in future we prevent it from recurrence. Regular training has to be given to people, and this should include even simulation, role playing, Drills should be brought in twice a year at least, so that we know that SOPs are in place and they are working and everybody is aware. Drill outcomes have to be reviewed, and if required, there has to be an improvement. Take feedback from all the people who are involved, all the stakeholders, and update any kind of requirement which is there depending on that feedback. So how do the institutions help to protect their staff? So there should be a relevant committee in place. There should be CCTV cameras so that we can capture whatever action is happening, and movement and suspected behavior. And public address system should be active. Strict monitoring of all the people, including visitors, limiting the visitors and the visiting hours so that not everybody on mob can build up, and having comprehensive plans for tackling of emergencies. Everybody in the hospital, right from the akka, aya, or security personnel, the person who's in charge of cleaning, and everybody should be ward boy, everybody should be trained, not just the healthcare personnel. And as soon as this happens, within 6 hours, the police complaint has to be lodged, and then further action has to be followed up. Further, some other things like where there are not adequate lighting should be provided, dark spots should be mapped, and very importantly, there should be duty rooms which are well equipped with basic amenities and well secured. There should be posters in different areas where it catches attention of people displaying the legal liabilities and consequences, and having a safety culture which is built up, a crisis intervention team. And very importantly, there should be a regular dialogue between the staff and management. So that's an overview about code violet and what it means and how should we go about. So I'll now hand it over back to my colleague, Dr. Vibhu, who will take us through the legal aspects. But I want to acknowledge CCI again, moderator Dr. Radha ma'am, and my co-panelists, the technical team, including people from Cipla, Mr. Vinod and others, and postgraduate Dr. Farah from my department, who helped me with the initial draft of these slides. Thank you.
Thank you very much, Dr. Animesh, for a crisp talk on the code violet. And right now, see, I'll be covering the other part, which is basically the sections that's helpful for doctors in case of assault or attack. So we all know that, once an assault or an attack occurs, then once you go to the police, they try to mislead you. So it's better to know these sections that under which you can file your cases. So first of all is your criminal conspiracy. Now, criminal conspiracy is when you have at least involvement of two or more people where they do not directly, impact your institute or you. They do not directly harm you, but they play a role in, having a conspiracy that they plan the attack or somewhere indirectly they are involved in it. And the final result may be unplanned, but the intention was actually to harm. So that is something which can be put up. Then you have the offenses under the public tranquility, that is like unlawful assembly. So where you have 5 or more people, who come at a particular point, which normally happens in case of any issue in a hospital or an OPD setting too. And that is something where they try to criminally put up a kind of a force, maybe a mental force or maybe physical force or whatever. That is unlawful assembly. Now once they go into a physical force, then you put it into a writing that it's not counted only as an assembly, because they've come and mentally harassing you, that's assembly. But once they start physically assaulting you, then it goes into writing. Another point is that of affray. Now, what you might see at times that in a hospital setting, you have people who have come and they're fighting amongst themselves. So they are fighting amongst themselves. They are not exactly harming any of the healthcare worker or any of the patients, but they're fighting amongst themselves. So that is taken as affray. Now, there is another offenses that is affecting the public health, safety, convenience, decency, or morals of public nuisance. So that can be again put up into this kind of a thing where you have a public nuisance, where you have a thing that somebody is coming and creating a nuisance. It's like in a hospital setup, he's playing loud music, creating troubles. That way kind of a thing is a public nuisance. Then you have offenses affecting the human body. That is like, so every hurt is not grievous. This is something which we need to understand. So, at times the police say, Doctor Sahab, आपका medical legal करवा लेते हैं, या that way types that or any healthcare worker needs to get a medical legal thing done, that we get your medical legal examination, and if there's anything, then we'll look into it. Remember one thing, uh, despite the fact that you may not have any kind of a grievous injury, there may be just a hurt which could be there, which is causing any kind of a bodily pain, or it may be an act endangering life or personal safety of others. This is something where a patient of, say, tuberculosis, or a COVID patient, known case, he knows that he has a problem, he's an open case of tuberculosis, comes without a mask and creates a nuisance. That is something which is the act of endangering life or personal safety of others. Then there is something called wrongful restraint, where you stop a healthcare worker from doing his duties, and then use of criminal force or assault is definitely something which we are all well aware of, and that is something under which one can be booked. Now, there is another thing which is offenses against property. Now, one is theft. Now, theft is something which is normally, you understand that the theft has occurred at a particular place, but it is, in case there is involvement of 5 or more people, then it is taken as robbery. It could be even dacoity if there are a larger number of people involved. Another thing to understand is that in case of theft, it is actually a physical thing that has been taken away, or has been somebody has put his this thing that this belongs to me is taken as theft, while in case of an immovable property, that cannot be a theft. It could be put into a case of robbery. So I'll give you an example, that a theft can be, you have something which is there with you and somebody steals it, maybe your pen or pencil or maybe stethoscope, while robbery is that you have a space in your maybe in your complex, which somebody else claims to be his, so that is taken as a robbery. And it could be even extortion. It could go to extortion also, where somebody say that I will do this kind of a robbery, or I would do this kind of a theft, the theft, in case you don't listen to me. So that is put into the robbery category. Another point is that of mischief, where you're creating a nuisance, where you knowing that it can cause a damage or a destruction to the property. It's like you put it, you have a glass door and somebody is scratching it, knowing well that that can cause the loss to the of the property, or the loss of to the owner of that property. Then one thing is that of criminal trespass. That is if somebody comes into your property and claims to be there and is not ready to move out. That is something which is that of criminal trespass. So imagine a relative coming and sitting over there, kind of a dharna, you can say, inside your property, is basically a criminal trespass. Another point is that of offense of defamation. Defamation, we all know that patient may use social media, or may use other sources of media to do defamation, to cause defamation to you. Then offenses of criminal intimidation, insult, and annoyance. Let me be very clear. I'm putting all the sections in front, where so that it's going to be easy for you to file the cases under these headlines. So when you say that criminal intimidation, insult, or annoyance, again, that is something that if you don't do this, I will do this. That is criminal intimidation. So at times it happens, a patient is brought in a very bad state, and where instead of a request, you are being intimidated to work on that patient, and they are kind of intimidate you that there will be repercussions in case the results are not positive. Then there are offenses of outraging, insulting the modesty of the women, which I think probably we all are aware of. And in case your resident or the healthcare worker is a female, then these offenses can also be put into force in case somebody creates a nuisance. then there is something called a law relating to sexual harassment. Now, this is something which I've put it not against, I would say that it is not exactly a point which is to be used for the relatives or for the, the patients or somebody from outside. But a woman can complain against the offense of sexual harassment at a workplace as per the provision of the Sexual Harassment of Women at Workplace Prevention, Prohibition and Redressal Act 2013. Now, these are all the criminal laws we were talking about. But one more thing is there are about 15 states and union territories which have the various legislations on the issue of physical violence, assault of doctors. However, there is no central law as of now, and that is something for which most of the doctor associations are working about. So this is about it. Thank you very much. I would now request Dr. Radha Munje ma'am to take over the panel discussion.
Yes. Uh, Thank you, Dr. Animesh. You explained code violet so well. And in fact, what should be done at the institutional level has also been explained well. And I'm sure few of us who have worked as administrators would feel that had we had these guidelines, probably we could have done something better in our regime. And Dr. Vibhu, you have taught us so many IPCs in such a simple language and slides which had least material but maximum you could convey to us. I feel few of us can really try to go in for that law degree if law is so easy to learn. But I'm sure it's not as easy as you have made us look. Wonderful presentations given by Dr. Animesh and Dr. Vibhu. And now we move ahead with the panel discussion. And I'm very, very happy to have all my friends as panelists here. First one is Dr. Indu, who is one of the leading pulmonologists from Mumbai, a good friend of mine. And I'm sure over few years, somebody would also be putting a label of, or rather, would honor her by saying that she is one of the social activists also. She does lot of these awareness programs also on not only on code violet, but other topics which are close to our heart. We have another panelist, Dr. Shajahan from Alappuzha, and even he has been on CCI webinars earlier, and I'm sure the audience knows them. Dr. Narayana Pradeep is one of the founders of, he's founder trustee of CCI, and we have heard him in various webinars. He's an active member of his own IMN as well as office bearer, if I'm not wrong, Dr. Narayana. And then we have Animesh and Vibhu who have already spoken. And now we come to Dr. Salil Bhargava, who happens to be a very old friend of mine and has worked in the capacities of administrators, all that can be done in a career of medical college. He has headed his own department. He has set up a new department in his Indore Medical College. He has been a medical superintendent for a long time. And then he was also the principal of his own medical school for a pretty long time. So welcome all panelists. And many of the things have been explained, but we would love to discuss a few of them that we have with us. So first question goes to Dr. Shahjahan. We have heard the presentation, but in your own opinion and experience, what are the major risk factors for violence in the hospital? I mean, how does it really start, you know?
Thank you, madam, for the kind words, first of all. And I congratulate CCI team for taking up this very relevant issue, especially nowadays. So we all know that healthcare settings anywhere in the world are high-risk areas. This is especially so in India due to a variety of reasons. The reasons can be many. From the patient side, if you look at the patient side, the attitude and behaviors of patients, family members, friends, and others who are often under highly charged, they are emotionally charged, and they have unrealistic expectations. That is one of the reasons. And also, we know that adding to this, many of these so-called bystanders are all maybe having a significant percentage of some under really stress, inability to deal with the crisis situations. Many of them have mental disorders, and also a few of them, not few of them, a good percentage we can say that influence of drugs, alcohol, etc., etc. So these are the issues from the patient side, and also from the side of the healthcare worker or the work or the healthcare workers. See, shortage of staff, especially in government settings, we have a shortage of staff, severe shortage of staff. Then a few of them are inexperienced or anxious in dealing with these kind of things. And many of them do not know how to deal with the mobs. All these issues can add on to the hospital violence. Then, of course, the system related factors are there. We know overcrowded areas, long waiting hours, there are communication issues, there is no control of states. This is very true with regard to government hospitals. People can enter anywhere in near to the, even near to the critical care areas. So that is a big issue. So free access to patient premises, we should avoid that. So that is one of the highest risk factor for having issues, because that, critical care areas, anything can happen at any point of time, but people are crowded there. In high-tech private hospitals, these usually do not happen, but in private government hospitals, these are the situations we see. And absence of security personnel, etc., are found to be major risk factors for having hospital violence. These are the points I want to raise with regard to the risk factors related to hospital.
Yes. Thank you, Dr. Shahajan. And you rightly said, unrealistic expectation, either in the public hospitals or when the condition of the patient cannot be ensured a best outcome, or they want that something else from the doctor, which really in that particular situation the doctor may not be able to provide. So that's good. But we have Dr. Narayana, the softest person on the panel. So Dr. Narayana, what do you think? How can these triggers be, prevented? How can can these be prevented, and how can we do this? Can you add a word on this, Dr. Narayana?
Yes, madam. Thank you very much for the outset. Thank you very much for the kind introduction. And prevention is better than cure. It is actually a proverb, but it is very difficult to implement. As Shajan sir told, triggers can be right from the beginning. Like patient comes with trigger could have started in the security personnel itself, that he's got irritated from there only. Second triggers, sometimes like from the reception, they will ask something and they will get irritated and their agitation starts. And when they reach there, already it is their mood is tuned to like attack the doctors. The last final step will be like attacking the doctors. So all these steps, there will be so many things will be happening in the mind, and there, as sir told, it is the patients and bystanders are stressed because of the fact. And from our side, what we can do is from the beginning only, right from the security level, reception level, then if we can little bit, at least 1%, 2% improvement daily, it will have a significant improvement over the period of time. It is very difficult in places like not only in government hospital, even some private hospitals with like less or relatively higher turnovers, with lesser security, people, it will be almost like a government setup only. There is no much differences except for the corporate hospitals or other things. People will come and they will start doing all the dramas. So it is very theoretically so many steps are there, but practically we have very much limited resources and very much limited things to settle the issues on a very fast track. But as the time progresses, definitely we will have more, we are having more manpower, we'll have more accessibility, then we have CCTV camera installations. Then these are small steps. Then our own personals more friendly with the grade 3, grade 4, all the, non-doctoral people getting more friendly with the patients. All these small steps will definitely improve the things. But very important is patients has to understand that this is from their side. If it is zero, as clap should happen from the both hands. If the other side, patient and patient bystanders will never improve means that situation will never improve. But they also have to be need to cope up with the things. Thank you, madam.
Thank you, Dr. Narayana. So now we know that this can be prevented, but only if we know what is going to happen. So my next question
I
is
think, ma'am,
for
no, ma'am. Before that, I would say that if you are a soft doctor like Narayana Pradeep, so then you're never
yes,
going to have a problem.
actually, इसीलिए मैंने बोला the softest person in our panel to answer that. So Dr. Indu, this is a question coming for you. What are the warning signs that some type of violent behavior or actions may be set off, and how do you identify them?
So basically, we as doctors, the healthcare providers, we all need to be alert about any confrontation that which is leading into the violence behavior or the aggressive behavior of the patient. So for starters, the early warning signs can be used as a stamp approach. There is a stamp approach which consists of S, which stands for a stare, staring. The patient has got a fixed stare, which is basically indicating for a quicker response. So many nurses have actually felt that the patients give them a stare to get a quick response. And when they respond to that thing, the violence reduces. So this is also seen in the bank. I have seen that there is a mob which, actually I can relate to that, because there is a lot of people who are standing on the top of the head of this bank manager and wanting the things to be done early, because everybody has to go to the offices. But over there, the violence doesn't happen because it deals with the finance. Nobody is dying, nobody is suffering, nobody's got the mental illness or a physical illness. So it doesn't happen. But the stare is very, very common. And then the second is the tone of the voice. So this is very common actually. The patient raises the voice, in aggression or in when they are suffering. They yell at the healthcare providers or the staff. Staff is a very soft target, I feel, and they start yelling, or they have some sarcastic responses also. So this is another warning sign. Then you have the anxiety, which is common in the emergency departments. So there is a expression of concern, or there is nervousness, so before it escalates to the dangerous levels, I think the doctor should intervene. And I strongly feel the communication gap is there between the doctor and the patient, which needs to improve. Of course, the gap is declining because of the lack of time, but that needs to be improved. I strongly feel for that. Then the other warning sign is the mumbling, which is basically the incoherent or the faltered response, which basically signifies the mounting frustration of the patient. And then there is pacing. There is this restless patient which is walking fast from one end to the other end, which signifies or indicates the mounting agitation. So one needs to identify this warning signs early and respond in a manner early, so that it doesn't escalate to a physical violence or a verbal abuse.
Very nicely explained, Indu. But I think I have to remember that acronym of STAMP. And if my patient finds me mumbling sometimes, I don't know what is going
Yeah, so basically it
So
goes
that was on the
the
lighter
context.
side of this topic. This is about the patient.
Ma'am, can I add a few one or two
Animesh,
more
the
things?
question is coming to you
Oh, okay,
also.
fine.
So you can
Sure.
add. Okay. So Indu has already told when we can identify something is going wrong with the patient, and this might escalate to the code violet. But what would be the early identifying red flags amongst the relatives or accompanying people, or if there is a larger mob? How can we, be cautious or forewarned? And what is the importance of identifying these red flags, especially when there is a large crowd?
So,
Dr. Animesh, this is for you.
yeah, I hope I'm audible.
Yes.
Yeah.
Yes.
So building on to what Dr. Indu already said, so she rightly said. Now the thing is, what happens is many times, like we will see what Dr. Indu has said, but other than that, there are some more warning signs or triggers which we can identify. One could be that we will see some people who are not supposed to be in certain restricted areas. They'll be around that, or they'll be trying to coming close to that and all that. They may not do something right away in the first instance or something, but they will be around, or Sometimes you can even equate it with like they are building up to doing something. Then sometimes we will also see that what will happen is sometimes we will see that there are no identification things, but they are accessing. So it could be like, anybody who is donning off the gear, like probably sometime like I can say uh, an apron or something, and in the garb of that they would like to come, and then kind of you can say that it's like fooling basically, or sometimes like deception. Okay, so these things are also to be looked into. And then we will also see that they will be very dissatisfied, or they will try to like again and again raise their this thing that, no doctor, but this is not helping. No, why are you not trying something else? I'm not getting benefited. And that will be the initial things. So it's good to identify these first initially. And I would go with what Dr. Indu was saying, that it's a good idea to identify these early and prevent the escalation or the build-up. And how do we do that? So again, going by what has been very importantly, and I think most of you senior people and some of our professors and teachers we have seen, they have the demeanor and calmness, and the way they interact, that itself soothes the patients. So it is very important for us to imbibe that somehow. I mean, this is again my personal opinion, and I guess many of you will agree with this, that somehow we have become more kind of restless. We are a fast food generation, or everything is at a click of fingertip, or whatever. So we want instant gratification, and the moment we are not getting an immediate thing, or then we get a little annoyed, or we are not very happy with things. So we want immediate redressal or whatever. But we have to realize that many times in healthcare and many of these disorders and diseases, it's not that immediate things happen, or we need to have that patience. And for that to happen, I think the first foundation is that we have to build that trust. We have to communicate, and we have to. I have had occasions where once or twice there were, during COVID times, if I can narrate an incidents. During COVID vaccination time, I was at one of the facilities because we have public-private partnership. So I was sitting there, and there was an elderly gentleman who came, and I was sitting in the officer's room, medical officer's room, and suddenly I heard something. So I came out, and I saw that one of my social workers is trying to tell somebody, that, sir, we don't have the vaccine available. And this gentleman was elderly gentleman, and he was very agitated. And he said, how can you say that? And see, we have been, wanting to get this, and I've taken an auto and come and this, that. So I just saw that. Then I said, relax. I just signaled, and I said, so I went and I wished him, and I talked, and I said, sir, please come in. It's hot here. No, I want my wife. I said, sir, please listen to me. And made him sit down. Sir, please have some water. No. I said, no, have this and let's talk. Tell me your problem. And then believe me that he started, and then I told him, sir, see, it's not under our control. This is, I'm talking about the first time when the vaccines were launched. So I said, sir, the vaccine supply has to come. We will definitely be happy to give you. But if you're in urgent need, let me see which is the nearest center. He said, no, I read in the paper, this center has it today. It was given. I said, sir, I don't know about the paper, but it's not there and you can check. However, I will try facilitating. And I called up in his presence to the nodal officer, and I said, sir, these are the 2-3 places nearby. And if you wish, we can send you there. And by that time, he had pacified. See, the idea is we need to,
example.
Yeah. So exactly. So this is what, happens. At that time, if I also said, and how can you, and, as if we have no business, and why are we hiding from you and all that, if I started, he would have given back. Probably there would have been much more escalation. But that's how it happens. So, I mean, that's what I wanted to put. Thank you, ma'am.
Yes, thank you. And that brings to another important question, which has come out of your own example right now, which is for Dr. Bhargava. He has been, I think, in the longest tenure of being an administrator of a government medical college. And I think he must be having a big pitara of such incidences stored up. और शायद उनको एक याद आने लगे. But sir, Bhargava sir, does effective communication really help in reducing violence? One, the number of violence incidences as well as the severity of violence. या ऐसा है कि violence हो रहा था लेकिन आपने बात किया and it really decreased and it फ्यूज ही निकल गया. The बच्चे भी खुशी खुशी चले गए, patient और relative भी खुशी खुशी चले गए. So what do you think and what experience do you have?
Yeah, Professor. I'll talk in continuation with Indu and Animesh what they have told. I don't know whether somebody has done a survey or not. In what special situation the violence starts? I'll give you some examples. Young death, death during deliveries, death in a plant surgery, death after riots, somebody is bringing up, death after road traffic accidents. If you do survey, you will find these are the places where the violence is most of the time it starts from here in such type of conditions. Now I will come to my point. That is the communication skill. Communication skill is no doubt is very, very important everywhere in our medical science. And in fact, we should understand that. And what Animesh has said, a mature doctor talks very politely. He tells them what exactly the position is. We are trying our level best, but still the conditions are out of our hands. We cannot say that these are the problems. No, you cannot say that. The patient is dying fine. I have heard from the attendants, doctor have done their best. Still he has died, don't worry. They have done their best. So show them that you are doing your best. Tell them that what is the problem. You cannot help it beyond a limit. So if you communicate them properly, it's a wonderful thing and it will prevent some violences. The point is, should we start doing it? In fact, in our foundation course, in first year only, we have started talking about communication skill. At an MC level, we are again talking about communication skill. Should we start doing some workshops? And there should be a lab also where we should teach the communication arts. And if we do that, then certainly when the event is occurring, when somebody is serious, then we can use them. Particularly to the postgraduates, the communication skills should be taught very well. Particularly when breaking a bad news, when informing something which is not expected, the communication skill, that they should spend some time. Otherwise, certainly it is going to be, because the attendants are in panic. I remember one case in casualty. There was a person who was drunk, he fell down, and he has very bad injuries on his face, very bad injuries. And when the postgraduate was trying to clear them off, he was using very bad words. So it is the point from the postgraduate, he has to be very cool, he has to keep calm, and he has see that he can treat the patient as best as possible. So the communication skill, yes, one needs to be mastered into this, and it will certainly going to prevent some. There are a lot of examples where simply by entering a senior doctor, HOD, he comes in and he says that please cool down, have a glass of water, sit down. This was the problem. We have tried this, but still it's not working. So they cool down. They should be informed what exactly is happening. Thank you, Radha.
Thank you, Dr. Bhargav. That was a wonderful explanation that you have given. And really, we knew, we have seen, but we had not taken a cognizance that which are the conditions where violence happens, especially such deaths which comes as a trauma or as a shock to the family, something which has happened in the riots or accidents. Thank you for pointing it out, and we would keep our eyes open for that also. The next question is, before I go to the next question, whenever we talk about code violate, there are two parts. One is a legal part, and the other is the medical part. And for legal, though we have our own Dr. Vibhu, it's a great honor to have another panelist who is none other than the retired Superintendent of Police, Mr. G.A. Jagdish. So on behalf of the whole panelists in the webinar as well as the CCI family, we welcome Dr. Jagdish sir here, and I'm sure his input will be of a great help. I would have a few questions reserved for him. So before I ask him a question, sir, can you just put on your camera, Jagdish sir? And till then, Dr. Vibhu, how and when do we interact with police and judiciary system if something like this happens at a workplace?
So first and foremost, ma'am, I would say that interacting with the police itself can be a trigger for a bigger problem. Let's be very clear on that. So, like Dr. Animesh also said, you first of all have to maintain a calm, and we need probably, our undergraduates also, we need a training that how to interact with the patient, because most of the problems can actually be sorted with the tone of your voice. So that's my first thing. Another point is which I wanted to add was before we talk of the police, we need to understand that we need to put up certain laws on the boards or on the walls itself, like it happens in the banks. So when a patient looks at it, he knows that police can come. Though this kind of an issue can actually be resolved. Now the thing is, once you realize that the things are going out of hand, as Dr. Animesh Jain said, you could sense that there are patients whose relatives are not exactly those relatives. It's a kind of a mob which is coming, or you could hear them that they are planning to attack or do some kind of a big harm. Or if the argument has gone beyond a certain level where the situations may worsen, so at that point it is better to involve your own security officer, who can eventually have a backup with the police, the local police, so that if required, that police can come immediately.
Yes. Thank you. Do we have Dr. Jagdish sir here?
Yeah, madam. I'm here.
Oh, yes.
Thank
So
you. First of all,
welcome, and we are very glad to have you
yeah,
here, sir.
thank you very much. First of all, I would thanks to all organizers and participants also, because very important subject. Today's discussion is very important, and it's burning issue. You know that recent incident. I understand that recent incident in West Bengal also regarding a lady doctor in West Bengal is a deeply disturbing and tragic event. I wanted to tell something about this. I will come to the point now. In volatile situations, doctors' role is also crucial. At the same time, sometimes the police officers so major the in volatile situations in hospital settings. Local police officers also play a crucial role in maintaining law and order and safety and security. I'll tell you, madam. Particularly, I'm discussing with the police officer. I'm discussing with the doctors. I wanted to tell you that in volatile situations, doctors' role is very crucial. They should remain calm, empathetic, and communicative. And here is some key points I wanted to tell something regarding maintain calmness, show empathy, maintains calmness, show empathy, communicate effectively, prioritize safety, collaborate with the team, make informed decisions, focus on patient care. So maintain calmness regarding this. Doctor should stay calm and reassure the patient. This is very important. And at the same time, show empathy means doctors should understand and acknowledge the patient's cool atmosphere and concerns also. Communicate effectively. Clear communication helps patients understand the situation also. This is very important. Doctor should listen the words of the patient. At the same time, they should be very calm and cool. Prioritize safety. Doctors should ensure their safety and their patients also. Patients should be also safety. So collaborate with them, with the team, working together with other healthcare professionals to ensure comprehensive care also. Make informed decisions. Doctors may need to make decisions such as administering medications or referring patients to specialists. Focus on patient care. Doctors should prioritize the patient well-being and comfort also. So nowadays, I think all over India, this issue is burning. The role of doctors is very important. I think many of the doctors, majority of the doctors, they are very cool, and they will face all these things. So I have come across almost 34 years in the department. So from 1985 to 2019, I was in the department, Karnataka State Police Service, as police sub-inspector, as circle inspector of police, and assistant commissioner of police, and superintendent of police, and as well as deputy commissioner of police in Bangalore city. So this is whereas the role of at the beginning stage, as some doctors told me, that prevention is better than the cure. In that way, the doctors, when the patients comes to the patients or the patient custodians or patients guardians come to the police station, they should talk very politely and cool. I think these are the important points to the doctors. Whereas I'm not discussing with the police officer. When an occasion to discuss with the police officer, I would like to the role of police officers also. Thank you, madam.
Thank you so much, Jagdish sir. And
Ma'am,
I'm sure you
I would
also
like to
have.
say, I would
Yes.
like to say something. I completely agree to what Sir said. It was a beautiful thing which he said, and I think I just followed about an hour ago in my own clinic. So there was this guy who came to me and he had pain abdomen and the lower pain abdomen and also I said that this could be UTI. And he was like, doctor, let me be very clear. I am quite sure it is not UTI. I said, yes, you are absolutely right. But I am unsure. So that's why I want you to get a urine test done. So, I mean, I know you know more than me, but it's just that I may be wrong. And I know I'm wrong, but it's just that I would prefer if you could get it done for me. I mean, you're going to do a big favor to me by getting your urine test done. So that would be good. He was like, then he cooled down. He was like, okay, so what if it's not a urine infection? I said, then we'll investigate further, but I think it could be, urine infection. So if you could please. So it's like uh, you have to be very soft nowadays. The people are crazy. People are crazy.
Wonderful. So, Dr. Vibhu, you have given us one more tip that you can turn exactly 360 degrees opposite and say that you don't want to prove yourself right, but you want to prove yourself wrong,
Wrong.
that this is not the diagnosis and hence investigations are needed. That is also one good tip which we must learn. We all know that whatever we are discussing, in spite of many things being in place, many things not being in place, still few incidences happen. Our residents or doctors go on strike. And then the other staff has to run around. We do FIR, we take care of everything, then we promise for securities and so on. But apart from that, I would just state two incidences, and I would like to have opinion of Jagdish sir, Dr. Bhargav, and Dr. Vibhu in this. I had a resident, uh, and she one day came and complained that such and such patient was admitted to our ward. Patient died. All papers have been done well. Formalities completed. No complaint received from the patient's relative in any form during hospitalization, even later on. However, one of the patient's relative is shadowing. He doesn't say anything. He doesn't come near me. But every now and then, when I'm writing something on the table and I put up my head, I can see him at the door. Sometimes I can see him crossing the corridors in the hospital, and I really feel that I am being shadowed. So this is one incident on which I would like to have opinion. The second incident is one of the resident who was working in the casualty was dealing with one of the serious patients there, and few of the relatives came, and the rowdy one said that if something happens to my patient, just remember the day you step out of the hospital, we will deal with you. So this was also a female resident. So I wanted to know that it's not about male and female, but this has happened at a working place. So how do we interpret, as well as how do we go ahead securing safety of them, as well as not putting oil to the fire of those agitated relatives or whatever they have in their mind. Jagdish sir, can you give your input on these two small incidences?
Yeah, madam. I can understand. Whenever the law and order occurs, law and order, particularly law and order issue, you please inform I think, wherever in all over districts, all over state, I think 100 is the police call control room call is there. I think any small sort of law and order issues or any doubts about, sometimes people will tell lies regarding particular. Same time, doctors also support the police officers. So any sort of doubts or something is there, any regarding particularly injuries or assault injuries, accident injuries are there, they should inform the control room.
Dr. Vibhu, do you want to give your input on what should be done in this situation? And does it fall under any IPC? The two incidences I
The
told about
first,
the
I think the
residents.
first situation which you're talking, I think you're talking of a stalking kind of a thing.
Yes,
The girl
yes.
is being stalked. So I think that won't really it's a case of a complete stalking where you can put in the things of sexual harassment because it's a female, and the stalking of a female, and trying to about the modesty of a female. So all these sections could be initiated, but as sir said, that you have to approach the police. Now here the role of hospital, I would not say is there's going to be much of a role of a hospital, because she is being stalked. I'm not sure if she's being stalked outside the hospital also. I'm not very sure of that.
Inside the hospital.
Inside the hospital only. So if she's being stalked inside the hospital, then probably institutional FIR could be filed, and that guy could be recognized, and he could be debarred from entering the hospital. That is one thing which can be done. About the second one, that if I'm going to catch you out, and I'm going to harm you. So that is something which I've already told about, the criminal intimidation and all. That can be done. Again, see, I personally feel that these kind of cases should ideally be, filed by the institution, and not by the individual. The reason being very simple, that that person who is coming to you, she's a resident. She'll be here with for about 2 to 3 years. And no offense meant, the police is not going to file their charge sheet before years together, and then it's going to drag in the courts for years together. These cases goes on for years and years. So if it's an institutional FIR, then whoever comes on the chair, that thing goes on and on and on, and eventually that is going to be the deterrent. Ultimately, you need to realize most of we doctors are scared of going to the court, because we know that it's going to take us years together, and something or nothing may come out of it. I'll give you one very simple example. So I run a very small nursing home in Delhi. So I had this patient who came to me in the middle of the night at around 2 o'clock, 2:30. And there was an unconscious patient. So I referred that patient within 30 minutes to a bigger hospital, and we transferred. Now that patient went to another hospital instead of going to the hospital where we referred to, in a small place. And there the patient was kept for about 3 hours, and eventually went to the bigger hospital. And eventually after about 2 days, the patient died. Now that person, had filed a case against all the hospitals, including me, saying that I had delayed and whatever, but everything was on the paper. Now, from day one itself, the things were clear. But that case went on for about 5 years, I think. That case went on for about 5 years. So that was, I think, probably one of the triggers which was there to do law. That was the trigger to do law. Because once you get into a trouble, then you realize this is pathetic. And you were just going, half the time you were just taking the dates. And eventually what happened, that guy stopped coming to the court who had complained. And eventually all were let free without anything. So, I mean, these kind of harassments do happen. So going to a court or going to police is also a form of a harassment for most of the doctors. Now, imagine I was here in my institution. I was doing it at my place. Imagine if that would have been a case in my medical college, probably I would not have pursued or to do anything. I mean, it's on the other side, had it been on the other side. So if that's the normal kind of thing which we have.
Okay. So now that with such a great input, we move on ahead. And Dr. Narayana, this is a question coming from for you. Others can just drop a sentence if they feel that they want to add something. Do such incidences of violence occur only in big cities, or do they happen in villages? Is it related with the educational status? That is, the mob or the patient and relatives are educated or not so well educated? Does it happen only in the government hospitals, or even happens in the corporate? Does it happen in the small hospitals also, और अदर नॉन गवर्नमेंटल चैरिटी हॉस्पिटल्स? ऐसा कुछ डिस्टिंक्शन है क्या कि यहाँ ज्यादा होता है, यहाँ होता ही नहीं है इंसिडेंट्स, और यहाँ कम होता है? डू यू थिंक यू
हैव आंसर्ड एवरीथिंग मैडम?
Because does it happen? I'm asking, does it happen?
It happens because it's the basic instinct of the human behavior. I feel it can happen everywhere. In the smallest of the small places where only one doctor is available in the entire village, there also incidences are happening. Even the biggest corporate hospital with all the facilities, like even the CCTV cameras, with all the security guard. There also this is happening. So this is a universal phenomenon. And if you take in other countries also, it is not as much as in India, but it is still towards the doctors there is some this is there. That is what I understood from especially from the doctors who have migrated from India and working in other places. There's only that context I have of 1 or 2 generations also. So they also have the same gut feeling, like it can happen for them also in their places. But in India, definitely, even in the smallest of the smallest villages or even the biggest of the biggest, every places, even if it's charitable, maybe it may be, the response may be different, but overall situation is same, madam.
I want to add one
Thank
point,
you.
madam. Actually,
Huh?
education is not a criteria at all.
Yes, correct.
Literacy rate is not a criteria because it is most common in Kerala, most literate state too. It's very common, madam, here.
Okay.
Also, madam, I wanted to add that see in private hospitals, the reasons of the violence could be different in private or government hospital. Me working in a private hospital, I feel the reason is the high cost of everything.
The
You know.
question is coming to you, Indu, and I will put it ahead. But before I put it the question ahead, let all audience and the panelists know that we have 2517 logins. A huge number of people have joined to this webinar and trying to understand Code Violet. So congratulations, Team CCI, for having such a wonderful topic for today's webinar. So Indu, the next question is that do you often, like having been you are working in a corporate also, so do you come across that I was not knowing the cost is so high, then they start abusing just because they don't want to pay? I mean, first thing is they may not be, affording genuinely, but second is they are affording, they chose the hospital, but now when they look at the bill they don't want to pay and they start suddenly complaining. Then even non-affording patient would say that even if I can't afford, you have to treat me here because I have come. So do you come across these things and do they threaten? I mean, saying something, requesting, pleading, crying, I can understand. But do they threaten and does it lead to unpleasant experiences even in corporate? Can you add, Dr. Indu?
Yes, ma'am. So it does happen. I feel the high expectation of the patient is because of the high cost which they are spending from their pocket. Their purses are actually getting lighter in the first visit to the hospital, starting from the admission cost to, the consultation fees of the doctor, then the investigation, which we are advising, and then the prescription cost. So I think the expectation is already built up, and when it is not matched with the patient's expectations, then the agitation and frustration all builds up. So basically we need to understand the aggressive behavior or the tone of the patient has an underlying cause. It could be a physical illness, it could be a mental illness, it could be that the patient is not affording, it could be anything. So first we need to stay calm, as everybody said. We need to be quiet. We need to hear the patient out properly. Why is he willing to pay late, as in, a little bit later date? So are we accepting the late payment charges? That we need to see. And then further to that we need to recognize the behavior early. The patient comes with huge patient coming with an aggressive tone, threatening tone. We need to also tell our staff that you need to recognize this behavior and you need to register also in your database, because these incidences happen, it recurs actually. We have seen the pattern recurs. So we need to give the first aid to the patient, treat in the emergency, whether it is OPD, whether it is emergency department, whether it is whatever, you need to treat. You can't just say no to the patient at the first go. If the patient is willing to pay late, I think we should accept that also. If the patient is genuine, then be vocal about how the aggressive tone of the patient affects you. I still remember there was this one patient who had a very loud voice and he was yelling. I don't remember exact reason, but I actually told him, listen, your tone of the voice is you have a high pitched voice. It actually raises my heart rate. So can you be a little softer, because I have to see the other patients also. I think it's okay to...
You must be flattered.
So I strongly feel you should be vocal about how you feel about the other person's behavior, and the patient accepts that, and the patient says, I've got a high pitched voice and I'm sorry about that. If the patient is genuine, then of course you should avoid conflicts. You cannot exercise your own ego at that time. Like half an hour before the conference started, I was just talking to my staff in the OPD, and I just asked her, do you remember any instances when the patient actually insulted you, or verbally abused you, or threatened you, or anything? So she gave a few references. When there was this one patient who was not affording, so I had seen the patient, and the patient went to the waiting area outside for the payments and all. And she might have said, okay, these are the charges or whatever. And the patient said, no, I have already spoken to the doctor and we'll do the late payments. So, am I audible?
Yes.
Yeah. So basically the comment from the patient was, आप अपनी हाइट के हिसाब से बात कीजिए, आप छोटे हो तो छोटे ही रहो, बड़ों की जैसे बात मत करो. This is like half an hour back. She just told me about the incidents which happened in the past. So I didn't remember. So I said, did you actually tell me about this incident? Did you come inside and tell me? She said, yeah. And you told me, don't actually, don't get your ego in between and just stay calm and forget about it. So this is how we actually in the OPD, in the private practice,
But
would do such
I think in a private setup, what is most important is that you should be very clear about the charges, because see, what I have become is quite blunt now.
No, so that's what I was coming to.
You have to be
Yes.
very blunt. You have to say that, okay, these are the charges. This is what
Yes.
is going to be there. Fine, you can give the emergency treatment and all at a discount or whatever you want to do. That's a different issue. But once the patient is stabilized, tell these are the charges. This is how much it's going to charge. Late payments never come. Let's be very clear. And second thing, ma'am, Radha Munje, ma'am, you are in a government setup, so probably आपको नहीं पता होगा, but let me be very clear. A guy coming in an Audi is going to ask you for a discount, but a guy who is who is a daily wage worker, जो बर्तन मांजती है, वो discount नहीं मांगती है. ये बात याद
That's true.
रखिएगा.
I have
So
also
please be very
realized
clear on
that.
that.
Yes.
So patients are very different, and I think if you maintain your thing, if you want to give a discount to anybody, that's your call. But
Personal.
somebody should not, that should not come as a kind of a right to anybody. And once you give a discount to somebody who is rich, he feels that he's probably dominated you or something is there. So I think you should be very, very blunt. And in a private setup also, because I work in my setup as well, I'm visiting at a few places, and I've realized that's a beauty in most of these corporate thing, that you don't have to deal about the price and the cost value. There are agents who just go there and tell them, look, by evening, this much money should be deposited, and that's it. It looks very bad. It may be like, you may feel empathy and everything is there. But at the end of the day, just remember one thing. We are doctors, but remember, they are not only our patients, they are our clients, and they can go to the court any day and any time they want.
But still, I will add to it, like for non-affording patients, at least in the private practice, OPDs, we can give generics, we can actually not investigate so much and still treat
That's
the
your
patient.
call.
If we
I
are
think that's
willing.
personally, that's
Again,
personally
yes,
your call.
that's a personal choice.
That's a personal choice and a personal call.
Yes, so once in a while, we can actually cater to such patients who are genuine and probably,
Yeah, that's
accept
what I
it.
mean.
Yeah.
Dr. Vibhu, let us go back to your major role now in this webinar. So what if a patient is brought to an emergency in a serious condition, relatives admit and then they disappear. They just don't turn up. And then they turn up only at the time of discharge. Does this type of behavior warrant some action, some
Yes,
IPC?
definitely.
What do you do?
Definitely, ma'am. First and foremost thing is, if a patient has been brought in an emergency, I think probably most of the people who are working in a government setup would realize the moment you ask for blood, the relatives disappear. Everybody disappears. So that's a tactic which most of the residents also use to reduce the number of relatives. That you ask for blood, everybody has to give 1 unit blood. Come on, aa jao. So that's a different thing. But most of the times, what happens is that is the time when these relatives disappear. So once whoever has brought at the time of thing, there is an entry, and most of these relatives are even if they're disappeared from the emergency or the ward, they're somewhere around because ultimately it's connected to them. So it's not that they're going to disappear completely. They're keeping a very close watch on it. So the best option is you just say about 30 minutes once you have passed, once your patient is stabilized in an emergency and you don't find any relative whatsoever. If the patient can speak and tell you the details, it's very good. Otherwise, the best option is to inform the police that, look, this is an unknown, unconscious patient who is lying with us. And so that clears your first issue. The second thing is that they put up in a hospital. Now, if they're put up in a hospital, like in a government hospital, if they're put up, then it doesn't really matter as long as the patient is interacting, everything is going hunky dory, it's fine. But still, you need to have one relative with them because suppose that patient lands up in a cardiac arrest. Forget about everything. You are treating a case of say acute gastroenteritis, and the patient lands up in a cardiac arrest. So you need to have a relative. So you have to be very clear to that patient that, look, I need your relative here, and if he's not there, then just remember we have to inform the police. Most of the people, at least in our country, are still scared of the police. They will not be scared of the courts, but they are scared of the police. So I think it is better to inform. But the first thing is stabilize, look out, do your bit, then inform police.
Okay. Because I put this question especially because, these are the relatives who are likely to start pick up fights if the patient does not improve. Okay. There has been an input from Dr. Krishna, and we must appreciate that in his last 25 years of practice, he has not come across any incidents of assault, and not even his staff has ever suffered. And he says that it's not because we have something great, but he is blessed. But we are blessed to have two cool people, as I already said. One is Dr. Narayana Pradeep with us, and now we can add Dr. Krishna's name to it, even if he is not on the webinar. Now we go on to the other question. Dr. Bhargav, just a one-liner answer. We have heard Dr. Animesh speak what is needed to understand code violet, how to activate, what is to be done, and so on. But do you think that only private hospitals are well equipped, or they are also not, and government medical colleges also need? Do they have all these things in place? That is the first question. And what can be, really be done to make it a standard protocol there? Dr. Bhargav?
Right. Madam, I was dean at Government Medical College, Bhopal, and
Yes.
we have asked for NABH for our hospital. And in NABH, you have to follow all the codes. And this has nowadays, NABH is becoming mandatory for almost all medical colleges. So if you follow the NABH guidelines, then you are through most of the things very clear. So in our hospital, everything is there. Code violet, certainly we have to follow those also. But in bigger medical colleges, sometimes the public address system is not working. Sometimes, so what we do, we come out with some other systems, like we have emergency numbers which have been pasted in almost all duty rooms at ICUs. Please call on this number. So this may be one of the ways of bypassing it if it is not working, public address system and other things, because the older hospitals may not have public address system and other things.
Thank you. So, Dr. Shajahan, what improvements do you suggest to enhance safety at the medical institutions that you have seen, be it private, be it government, जो
Now,
अभी
most of the
existence
things,
में है, and you feel that this needs to be improved?
most of the things we have already been discussed. But to add on
Yes.
this, we should have adequate security personnel in
Okay.
different areas, especially in critical areas. Already, Dr.
Okay.
Vibhu has said, you are afraid of police. Just like when security personnel are enough, many of these things can be avoided. For example, nobody creates problem usually in airports. Why? We know that if you create problem, you will be in real drive for the rest of your life. So
Yes.
that is very, very important. Adequate security personnel. We doctors are soft target always. So there should be adequate trained security personnel. Not the security personnel we employ nowadays, especially in government settings. They do not know. Even they are not in a position to run. They are very weak persons are nowadays be putting us security. Not like that. Real security person who are trained. Then we should have better light, simple things, but we should have better lightings. Especially in the long corridors. We know there won't be light. Even if there is light, it is already fused. Many things are there. Better lighting is very, very important. In the lighting, many things can be avoided. More CCTV cameras has to be installed everywhere. And more importantly, we should display you are under camera surveillance. That is also important. If you see that, oh, you will be okay, you will make it like that. Otherwise, you will create no problem. These are human behavior, as Narayana Pradeepa has already been said. So that is also important. Then there is availability of panic buttons, especially in emergency rooms, critical care areas. Wherever we expect trouble, we should have panic buttons. Then regular security awareness programs for healthcare personnel, including doctors. We should know what is the situation going on in our institution. That's also important. Then another thing is that, see, madam, you must be knowing very well that in our hospitals, everyone can reach everywhere, even into the labor room or in CCU. That should not happen. We should have restricted entry of people, unwanted people to enter into the hospital. It will not only health risk, but also it can create a lot of health related issues to people, patients, doctors, and other staff too. So these are the things generally I think we have to think about additional measures to free our hospitals and healthcare settings from violence. Thank you.
Thank you, Dr. Shajahan. Jagdish sir, I would like to bring one question to you. How many institutes approach the nearest police station in their circle for with a request to make a security audit of the institute? One. Secondly, when police undertakes the security audit of the institute, what are the things that you look into? And what do you suggest to that particular institute? What needs to be done to have the best possible security?
Yeah, regarding any law and order issues, then, madam, we are supposed to, I think, discuss with the superintendent of police, district superintendent of police, and as well as the DYSP headquarters. We are supposed to give it in writing, says that there are issues relating to the law and orders or any other issues. Police definitely they are going to support, but at the same time, they should cordial relations should have the particularly medical officer, a medical officer as well as the police officers concerned. They should have cordial relations, and whatever the problem is there in the hospital premises, whether it's the private or the government, they should inform the police authority, and they should get the permission. They should get the safety as well as security measures also by the police only.
Thank you.
Madam, and at the same time, I wanted to tell you one last thing. Just I will leave before leaving. So regarding some of the doctors told me that the waste of time in the court is very, very important. Giving evidence, medical certificate. I think medical certificate itself is enough. Even in court also they should accept it. So whereas in all courts, particularly in Karnataka, wherever the courts are there, courts are summoning the police officer along with the doctors also. Doctors are absolutely, they are not necessary to give evidence whole 2-3 days, 2-3 hours, 3-4 hours, 5 hours, waste of time also. All the doctors, they have, I think, association. Through the association, should fight in the court of, fight in the government level. MLAs, through MLAs and MPs also, we should contact the MLAs, MPs and tell all these issues. So waste of time, instead of waste of time in the court, let them use in the hospital. Time you can use in the hospital. Right, madam. Thank you.
Thank you, Dr. Sri Jagdish. And we are really very happy. You have been very kind to give your suggestions, come on the webinar live, giving your opinion and guidance. We are very, very grateful to you. And I extend thanks from whole of the CCI family to you. Thank you.
Thank you. Thank you. Thank you very much. Thank you. Thank you all.
The
Thank
webinar would move on, sir.
Yeah, please carry on.
Many questions.
Thank you so much.
The audience has many questions in their mind. So, Animesh, this is a small question, like you have already quoted one example of the COVID vaccine in an elderly. How do you handle non-urgent patient coming either late when the OPD is closing down or coming to casualty and then pressurizing for urgent checkup?
So, as I understand, ma'am, the question has two parts. One is that, how do we handle such people who come to casualty and it's not an urgent case, but they want an immediate redress, or they are coming during the closing time of the OPD. Is that right? That's what I got.
Yes.
So, yes. So, basically, again, see what happens is, I think one of the panelists also referred to it, that since we are in healthcare, they are expecting us to redress their problems. So if it was supposed to be say a restaurant, and if it was closing, and if we reached there and they said, sir, sorry, we are closed, what do we do? Do we, raise our voice, or sometimes we may, but do we start assaulting them? We don't do that. But here it's our right. We think that, how can you refuse? So soft target is one. The other thing is, when it's healthcare, everybody wants that, no, I need the best, and at the same time, at the same moment, immediately. Now I think we have to have 2 or 3 pronged measures. I feel that we have to start educating the public that, see, these doctors are also human beings. They need to understand that, they are also human beings. They have their own physiological needs as well, and they have their other duties towards their families and others. So that is one. Second thing is, when we have got into profession, there is a concept of fiduciary duty. So we also have to always look at the benefit of the others, and in this case, our patients, our clients. Now, this concept has come in the MBBS curriculum with EdCom also. There is one particular module which talks about fiduciary duty. However, what we have to understand is, sometimes this needs to be told to the patient that, see, okay, you have come, we have checked. However, to get the best, I think you should come back for a better consultation and with my team tomorrow or something. So when we start doing that, they will understand. The second thing, as I said, is also to create awareness that they cannot just come in and barge in anytime for non-urgent things just because things are available. Third is, in some places now they have started late evening and other clinics, because working professionals sometimes get time only in the evenings. So they have started some late evenings, and some places it goes on till really late. So what they've done is, like, people who finish job by 7:30, they can come after hours, and then they can. So such things can be also told that probably you can utilize such services, or there are some appointment-based services you take for certain conditions which don't require urgent. And again, I will come back to what I said earlier. Communicate. Tell them that you have their best interest in mind. You want to do the best to them. And that's the reason you are saying that. It's not any other intention. It's not any other thing, but you want them to get the best out of whatever is the available services. And that's how you're doing it. Once they have that trust, I can bet on this, that nobody will take any other route, but will come back and will understand, and probably send back more patients to you.
Now we have a question that we know कि सबकी जड़ एक ही है कि communication needs to be good. But most of the time when incidences happen, especially in teaching hospitals or medical colleges, it's mainly people start, like complaining, and they talk about that the residents are under a lot of stress, and that is why they said this and this happened and that. So the next question is coming to Dr. Bhargava as well as to Dr. Indu. You can give your input from your own perspectives, that what methods can we do to reduce the stress amongst our residents? Or
Dr.
they may not be resident, but at least the junior doctors who are working with you.
Dr. Radha, I can see that out of the panelist and out of the listener, most of us are slightly older people. We were in medical college about 25 or 35 years back. Now the scenario has changed. The government hospitals are still very busy. The facilities are better. The government schemes are there. So a lot many people are coming. So pressure is there. You can see the number of outpatients are increasing. Number of deliveries are increasing. Road traffic accidents on holidays, nobody is there to help them. So they have to go to the medical college. So there is a lot of pressure on the medical college team. And naturally, our backbone is our postgraduates. Although the NMC is continuously increasing the number of postgraduates in the departments, faculties and other things are being increased with the state government and other people. But certainly, no doubt, there is a stress on the people, on the postgraduates. Can we do something? Yes, we can do few things. I've done it in last few months. We can talk to them. At least I request my HODs to please talk to them, sit down with them. What do they want actually? Are their duty rooms okay, safe? Are their duty rosters are comfortable with them? Please reduce that. Whatever is best can be done, do with them. But sit down with the postgraduates, just listen them. And other things we can, on a college level, we can organize few talks with some spiritual teachers, Brahma Kumaris. I've done that. Some psychiatrists can come and talk how to keep cool, how to reduce the stress. The most of the time, the stress is because of their pressure on thesis, one, and number two is their duty hours. These are the two things. In fact, I used to get call every 15 days, sir, I want to commit suicide. Oh my God. So every time somebody comes to me, I have to find out where is the problem. The problem is that he has a lot of duties. And now I'll tell you, now the children are difficult. When we were entering in the medical college, we knew that we have to work hard. We used to do the 36 hours duties and we never complained to anybody. But nowadays, the scenario has changed. Lot many things have come in and they are pampered child. They are not ready to work hard. I know the surgery, orthopedics, gynae people, they are ready to work hard because they know a lot of patients are there, and if they will not work hard, they will not learn it. So we'll have to tell them, this is not to put you under pressure for work. This is for your training. If you cannot do it, please inform your HODs. So the children are slightly difficult. We have to understand them. We have to sit down with them. And if they have issues, even head of the institution, head of the department, the faculty members, they are responsible for reducing their stress. They have to sit down with them, talk with them as you have been talking to your children, and see that you can do something for them.
Thank you. Indu, would you like to add something?
Yeah, so sir has covered everything very rightly. He said that, counseling sessions can be there with the doctors. There could be paid vacations or some trips, group trips can be organized to reduce the exhaustion, because a mentally exhausted doctor and a burnout doctor would obviously make mistakes, So to reduce that, I think these counseling sessions are very much required. And then, of course, the better staffing patterns, reducing the number of the working hours or lesser night duties, lesser of the administrative work for the doctors, which many a times they actually get into administrative work also. And I feel the automation of everything, as in the technology, plays a good role in reducing the workload on the doctors. So all the investigations and everything can be on the can be dealt with the technical thing, softwares and all. That would reduce the pressure on the doctors, I feel. So, yeah.
I would say one thing, as sir mentioned, the present generation is like that. So we need to understand, when we say the patients have become more aggressive, remember our own children have also been, that is also the present generation. And probably I personally feel that, my churning of doing 36, 48 hours duty is having a lot of pressure actually helped me over the period of time, because remember, life is going to be full of pressures. So we have to tell them that, look, it's not about being a doctor only. I think every profession nowadays has a lot of pressures. What is happening with our children is, I don't disagree that even I'm wrong. I'm also trying to make my children's life more comfortable, much more comfortable than mine. Now, the problem is when you put too much of comfort, their life is full of comforts, and suddenly you tell them that now, babies, you are 18 plus, now you're in a medical college. At 23, now you have to deal with the mob. And they're like, oh my God, how could this happen? Because I was sitting on my crib and having my milk and diapers being changed by my parents. Now you suddenly, all of a sudden, you have to do that. So I think somewhere down the line, I think it's more to do with the parenting and the kind of things. But definitely, I would say that instead of reducing their burden, what is important is to deal with their stress levels and tell them that, look, life is going to show you much worse than what you're seeing in a medical college. Just remember that. That's my personal take. I mean, I'm being very emotional on this. And then I tell my children, कि look, अभी तो पापा कर रहे हैं, but आगे का आप देख लो भैया, तुम्हारे को सोचना है. Life is going to get tougher.
Agreed.
Ma'am,
So
I
we
would
have
like
had
to add.
wonderful views from
Ma'am,
Dr.
may I
Radha.
add something? May I add
Yes.
something? So I
Yes.
totally agree. In fact, I could see that Salil Bhargava sir's experience was talking, and I could see that, how emotionally Dr. Vibhu was and how he was relating to his experience. And I totally agree on some of those things. And of course, Dr. Indu has given us some food for thought, including paid vacation. I want to add that other than that, we can also try and address them right in the beginning. What we do is we have PG orientation, and I think many of the institutions do. So right in the beginning, there is an address by the head of the institution. They tell them what they're getting into. So again, setting realistic expectations. They should know, because see, when they get into this profession, they have to understand what is the reality and how much they need to put in efforts. And another thing, over a period of time, because see, it's like even in the army, you have a brigadier, you have a soldier. Now everybody has different. Once you have gone through that grind, maybe after a few years down the line, you will be, in a better position probably. But as of now, when you have to go through, see, sona bhi tab ke hi khara hoke nikalta hai na. So that's what they have to understand. And other thing what we can do is we have certain kind of avenues for them. So we create avenues like, they have sports competitions, they have cultural competitions where they take part. So we have these things built into. They have, academics, they have other things which, so these are also built into. So what happens, this also acts as a stress buster and a reliever. And
Yes.
I totally agree that even sometimes the senior professors and head of departments also need to, sit down and talk to them. And again, it boils down to listening and talking to them is also again communication. So I think we also have to look at our own selves and our systems and introspect that where are we also probably not meeting their expectations or going wrong, and listen to them, including he talked about comfort, duty rooms, the duty rosters. And to an extent, we also have to tell them that yes, but everything is not going to be addressed the way they want it, because when they have got into it, they have to set realistic goals and expectations. It can't be a cakewalk. They can't become the best if they have not gone through some of this hardship. But at the end of it, there will be, of course, going to be a best thing that is waiting for them. So that's what I
Yes.
wanted to add. Thank you, ma'am.
Madam,
So, in a
can I add one
nutshell, what
point, ma'am?
Dr. Bhargava said, Dr. Vibhu said, Indu said, and Animesh also added, it should be a chai pe charcha with the seniors and the newcomers. We should be explaining to them. Can you hear me?
Yes.
Yes.
Yes. We should be explaining to them that there may be few hardships, but these hardships are going to prepare them for their own future ahead. And in case they cannot bear with it, the best thing is they come back and communicate to us. We can help them identify what is the issue with themselves. क्योंकि हर एक का प्रॉब्लम सिमिलर होने के बावजूद भी अलग हो सकता है, हर एक का ट्रिगर अलग हो सकता है. तो it is for the us in that family to identify these stresses and teach them. You cannot remove it. We have to teach them to deal with these stresses in the best possible way, so that even their persona is built up to tackle when you are not around. So thank you, that was wonderful. We have few questions and I hope we have the time to take up ahead that. Dr. Shahajahan, this is a question for you. We all know that we have loads of screen time. The children are watching the screen since their childhood. Not only the medical students who come to medical school, but also the mob which is coming to the hospitals. All are influenced by media. So, do you think the media has a role in escalating the violence, and do they have similarly in de-escalating the violence in the medical setup? What is your opinion? Dr.
Absolutely,
Shahjahan?
madam. Absolutely, madam. It's a very important question, actually. Actually, genuine reporting of the facts are very, very important. And unfortunately, in a country like ours, what happens is that many a time these people, media people, go with the emotionally charged people to make it sensational and live. So this is very, very unfortunate. I am remembering a recent development in our state, actually. What happens is that there is a case of reoperation after a post-operative hematoma development. It is common and natural. So what the media reported was that the reoperation was for removing the cotton bud. So it created a lot of havoc. And see, this, as Madam rightly said, these are viewed by the college students, politicians, other people. Everyone is in the mobile. So people are watching it. So people think that doctors put cotton bud, forgotten cotton bud. So that was the issue. See, actually what happens is that it was a simple post-operative hematoma. It was natural to reopen it and remove. So this kind of reporting will not help. Actually, media should have a responsibility to the society. So they should report it in a restrained manner, especially sensitive issues like this. That will ultimately help only the patients and the society at large. See what happens if the media is saying that this particular government hospital or some other hospital is not at all good. People will go a distant hospital where the cost is so high. So the ultimate losers are the patients and their families and society itself. So media reporting is very, very important. Actually, they should have a guideline, especially with the suicides, and also media got a guideline how to report it. I think CCI can do that. A guideline should be formulated how to report this kind of ways. Of course, if there is a problem, if there is a lapse from our side, they should report, no doubt about that. They are very, very important pillar of our system. They should report, but it should be a fact and fact only.
Now, what you have said about the media, it brings up another important point which we must discuss here. And I would like to have an opinion from each one of you. Are we responsible for some episodes or incidences of violence when we have a loose talk amongst ourselves or with our colleagues about other consultants whom the patient have already met or who has given a particular diagnosis and treatment? What is your take on this, Dr. Bhargava and Dr. Animesh, Indu, of course, Shajahan and Dr. Narayana? Everybody. Just a single liner.
Yeah.
I would appreciate.
It's absolutely correct. If there's a problem, healthcare personnel, especially one doctor, should be there to have the issues perpetuated or issues escalated. If we ourselves show restraint, most of the problem can be avoided.
Dr. Radha, I will like to inform everybody here, please don't criticize a physician who has treated previously to this patient. Because nowadays what is happening, they will ask you, Doctor साहब ये सब ठीक है, ये इलाज ठीक हुआ. They are keeping their mobile on while they are recording the discussion with you, and they use it at some place. So be careful, please never criticize your friends or whatever has happened. जो उन्होंने किया बहुत अच्छा किया, जो उन्होंने समझा अच्छा किया. अब अपन आगे देखते हैं. So at some point of time, we are also responsible for creating problem for our friends also. I tell you honestly.
Thank you. Indu, would you like to add something?
Yeah, so basically, you can always respond by saying, I was not present at that time when your problem happened. So, the treatment which was given, I would not be in the right position to opine on that, if you don't want to say anything wrong or right about it. But I think that's the best approach, I feel, which you can speak about it. You can tell your patients.
Dr. Narayana?
Yes, madam. Never do the professional journalism. That is what we in every meetings, IMA meetings and our professional meetings, we tell. Professional journalism is the one of the cause for the triggers of professional increase in the violence as well. So never
Animesh,
criticize.
You want to add something?
So I agree. I agree with all the panelists that they have expressed. What we also do, ma'am, is now we have started last 4 years. We do a workshop in small groups for all the postgraduates for a half a day on professionalism and ethics. And we also do on communication. And we bring up we give them basics and we give them different scenarios, and they have to come and enact, and the others have to, give points. And then, so we've done that. To an extent, I think that's working. We include scenarios like, what you said, talking bad about, or, these kind of, where they are in a situation and they have to inform somebody. So, or they have to inform consultant, they have to write a letter to or email to the faculty about their thesis. So all these things we are covering, and that's actually helping in some way. And this has been formulated based on our experience and our colleagues' experience. So we also review, we have modified in the last 2 years again. So we are trying to address. But I think at a larger level, we can come out with this kind of course. I have already proposed at national level in my association for having an online come hybrid kind of a course. So I think we have to think of this as well. Thank you.
Good. And now we come to Dr. Vibhu, your opinion, one. And secondly, if such loose talk is done, is there any IPC for that? Even if somebody does not record.
So let's be very clear on two things. That first and foremost thing is that if there is a gross negligence, then you can't do anything much about those things, right? So if you had to be operated for your right foot and you are being operated for your left foot, then nobody can save you. Let's be very clear on that. So that has, and those are the incidences that have happened in some of the biggest hospitals in the capital. So I know about these incidents happening. Now the point comes that normally when a patient says that okay, you are treating it this way, and the other doctor was saying this, so I always tell them that look, you reached my clinic. There are three ways to reach my clinic. The one which you chose is also right. Suppose you would have chosen the other one, you would have reached the same place. So just remember, we can have differences of opinion, and I always tell them that in medicine there's nothing like 2 plus 2 is 4. In medicine, doesn't work like physics or mathematics. Medicine works in a very different way. Your human body, the same medicine can have different effect on different people. So this is something which I think instead of really supporting your colleague, you can always be in a very diplomatic way. Even if you find that person is not right, you can be diplomatically, you can just say that okay, this medicine probably did not work in you, but it works in most of my patients. So those kind of things can happen, but definitely if it's a gross negligence, then there are issues and then you are in trouble. Nobody can save you.
Yes. We have a few more questions remaining, and few questions are coming up also. What does today's violence movies, are they a reflection of the society, or do the violence in the movies reflect on the society, vice versa? I would like to have everybody's opinion here. We talked
I
about
would,
media. Now we
so
were talking
I'll,
about the movies, which goes
yes.
to, and we as Indians are very fond of movies, you know.
Yes, and I would like to speak on this, particularly being a pediatrician too. And this is what the problem I'm facing with the children also nowadays. The children, 5, 6 year olds, are getting very aggressive. And it's not only the kind of movies, the kind of cartoons which they watch. So you realize that overall, it does have somewhere down the line, it has an impact on your own social persona. Right. So you have movies like you have cartoons like which a lot of children see, like the Shin Chan and all, which are very aggressive cartoons. And then you have certain cartoons which are very soft. So if the child is watching a very aggressive cartoon, you'll find that child to be very, very aggressive most of the time. They try to imbibe. And I think in a fast paced kind of a life which we have, I think there's a lot of frustration which is there in the people. As I said, most of these are the diaper babies at the till the 18 you were putting them in the diapers and suddenly you've put them in the world. So they're not able to handle those pressures. So they are very frustrated. Now they watch these kind of movies, they try to relate to that, and then the aggressiveness comes. So definitely it's we need movies to cool down, to calm down, to relax. But nowadays the movies are such that once you come out of the theater after 3 hours, your mind is completely bonkers. I watched that movie Animal. I loved it. Okay, but that movie when I watched next day, I felt okay, I should have a gun and I should just go out and shoot anybody. That kind of a thing. Whoever I don't like, I can do. I mean, that kind of impact. I think probably is there, and in every human being. Because remember, I may be a doctor, I may be a father, I may be anything, but then I'm a human too. So if I could have that kind of an impact, that macho kind of a thing, probably a lot of other people do, and those who are less educated and the younger, the young blood which is boiling already, you give them a lot of more this kind of a petrol, they are going to burn out. So I think we need to have movies which are softer, which are you have so many movies which are like comedy movies. You go there, enjoy your 3 hours, you come out happy, you don't come out aggressive. So that is definitely having a lot of impact.
So,
Thank you, Dr. Vibhu. I wanted other panelists to add a sentence. Yes.
yeah, so I just remembered, see, media has a great impact on the people. Like nowadays, you see children throwing these names, I have got anxiety issues, I have got bowel issues. Very casually they mention that I had this trauma, childhood trauma. It's very, very common. We didn't
Stress.
even know the meaning of these words earlier when we were growing up. But now, like I was abused in the childhood, or I had mental trauma, and I have this thing or that thing. So it's very, very common. What I feel, in a way, it is a good thing that at least, there is a emphasis. People are aware about it, okay, what are these terms, when you can approach to a therapist, but it should not be like everybody is speaking about they have a therapist. Every celebrity has a therapist. Every person, a young person, male or a female, has their own therapist nowadays. So in a way, it has got a positive impact, but in a way, we all have seen certain movies wherein doctors are portrayed in a negative aspect, which I feel it creates an impact for a long lasting period, so these kind of movies should not be made. Awareness is a different thing, but yes, see, somewhere things might be happening. It's a big country with a lot of population in our country, and various treatment. So I think things do happen, but picking up that one incidence and throwing doctors in a bad light is not a good idea, I feel. And these things should not be highlighted in the media. They should have a proper responsible role, I feel.
Dr. Radha,
Anybody else wants to add? हाँ, Bhargava sir,
Here,
बोलिए.
here again, a self-restraint is important, madam. Just like this will act as an environmental trigger. But this is a big issue in every sphere of life. Actually, the filmmakers, society, all should sit together. The psychiatrists, the policymakers should sit together, because it's a global issue, not related to health-related issue alone. It will affect every sphere of life. Actually. It's a
See,
very,
but
very
for
big issue.
movies, there is creative liberty.
Yes,
They have a creative
yes.
liberty,
Of course, it
Dr.
will act
Bhargava,
as
आप
an
कुछ बोल रहे थे?
environmental trigger.
Dr. Radha, you mentioned about movies. It is not only movies, the OTT channels too.
Yes.
Then the serials, TV serials, the WhatsApp small video clips, they all have changed the way the people are talking. Just listen the language, how bad language sometimes they are using. And if they are not behaving with properly, they are not putting the proper image of doctors and hospitals, then it is the duty of our associations to raise the voice against them, as we have been doing at different platforms. You cannot change the producer director's view, because they show the things which people like. So our society likes them. That's why they are showing such type of things. And at some point of time, if you can raise your voice, you can write them, please don't do this. Otherwise, it's not going to change. It is changing with the society pattern, the atmosphere, and the pollution is happening everywhere.
Also, madam, I feel nowadays everybody, all the doctors are also, many of the doctors are on the social media creating awareness. And simultaneously, the trolling also happens. So is the violence, which is virtual violence, or the trolling, or telling a doctor that we will give a negative feedback or whatever, is that also comes under the definition of violence? I really want to know. Because
Dr. Vibhu should be able to answer. But before we put that
Defamation.
question to Dr. Vibhu, I think there are two things which have come out in today's webinar. One is like having guidelines on about that, how do you convey not having loose talk. And the second one is raising a voice if you see something which is derogatory to the profession, or doctors and association must rise for that. Yes, Dr. Vibhu, sorry for interrupting you.
No,
Please
that's
go
okay,
ahead.
ma'am. So basically, one thing is that, as she said, that social media and also one is criminal intimidation, and the person is trying to defame. That is defamation. That is, these are the few things under which you can file your cases. So I think in my presentation I had given those sections. So I think it's like what happens when you go to the police. The most of the issue which occurs is कि डॉक्टर साहब किस में करोगे ये वो, and he also, the police also tries to tell कि you sort it out amongst themselves. But if you go with these sections, that these are the sections under which I have been harassed and I think this person should be booked, the policeman is going to take you very seriously and is going to work on it. So there are sections if they're doing criminal intimidation, then defamation. These are the other things in which you can do. And as a female, you can also put it as sexual harassment or outraging the modesty. All those kind of things can also put in.
Nothing actually happens in India.
No, that's what I said. Once you go to the court, then you
I have
are
a
harassed
question
even more.
now.
Yeah, exactly. We all know that how it goes, and how much time it takes. So we had in our clinic this blank calls which used to come on the regular basis, and I had actually personally went to the police station and complained for it. We had the numbers also. We forwarded the calls on the mobile, and we had the numbers. But that's what I'm saying. Nothing actually happens. Even if you follow up, you don't see any result. So they only make the.
Yes.
Let's
We
not
have
do
a
that.
question now for Dr.
That is the
Bhargav
importance
and
of
Dr.
association taking
Animesh.
up these issues.
But the sorry, can I move ahead now?
Yes,
Yes.
ma'am.
We have a question for Dr. Bhargav and Dr. Animesh, and of course, the final verdict would be given by Dr. Vibhu. Whenever there is a fight between the students of a teaching institute and the security personnel, or the Aya, or the Mama, Mercy, Bhaiya working in the hospital premises, अगर उनमें झगड़ा होता है, verbal fight, physical fight, so does it result into the internal code violate? That is the question. And how would you deal with this?
Yes, code violet, Animesh will answer it. But certainly there is some disturbance in the working. Yes, it should be handled properly. This has happened 2 days back in my hospital. And I tell you what should be done. I have seen at least 25, 30 times this happens. What will happen? Both of them will go to the police station. They will make an FIR. And at that time, the nurses along with their friends will go. Doctors along with their colleagues will go there. After 3, 4 days, both these guys will be visible in the court alone. Nobody is there with them. This goes on continuing, and later on, they go for a compromise. So nowadays, my style is, or my method is to call both of them. Whosoever has done the mistake should say sorry to their colleagues, whosoever it may be. Maybe a sister, Aya bhai, if you have done something wrong, please say sorry to them. There is no point in going to police, court, as doctor has rightly said. Nothing happens in the court. It takes a lot of time, and both of you come back and spending a lot of time and money, and nothing works. So please, if the internal problems are there, the HOD and the administrators should sit down, should solve the problem, and there should be a communication between both of them, and whosoever is at fault should say sorry to them. This is my take-home message. Yeah.
Animesh, do you want to add something?
Yes, ma'am. So I agree with sir, but to answer the first part, that code violet, to the best of my understanding and knowledge, it should not be code violet because it's not related to a patient or an unruly mob, or it's an internal people. And I don't think it's what you mentioned was related to a patient or patient's treatment gone wrong or something. If that is the angle, probably then we can think of, but otherwise it may not. But it definitely is a problem and an internal problem. And then we have to look at our systems in place. And then we have to also look at strengthening the systems as well as the training. And coming back to it, agreed. There is the best way would be to see to it how to solve this and make sure both the parties reconcile. At the same time, learn from this, take the lessons, implement it prospectively in a preventive fashion, and create systems again to prevent such instances in future, because this is itself a learning point where we can think that why did in this first place this happen. So I would go in that way, and then also bring those parties and see to it that this is looked into and investigated. If required, even disciplinary action. It could be a suspension or some kind of disciplinary action which sends a message, so that even it acts as a deterrent for the next something which might be brewing. So these are some things which I would say, but definitely not taking it to any police or anything, because this is not the solution, definitely, and it will take ages and years.
So we have had a wonderful perspective on how to deal with the internal conflict that we have. Dr. Vibhu, there is one question which has been pending. Right to refuse a patient, is it absolute? Number one. And does it, if so, does it rest only with an individual who is practicing, or it can be even in a multi-speciality or a corporate hospital? I cannot say vouch that for public hospitals or government, but at least in private, is it an absolute right?
So right to refuse in a OPD definitely is your absolute right. As a doctor, you can always refuse whether you are in a public hospital or in a private hospital. You can always say that I don't want to see this patient and that can be referred to somebody else. But when it comes down to whether it's absolute, though, you have to understand that this patient, suppose, is a critical patient. Now that and you are the one in the emergency and that you remember, okay, I had a trouble with this patient, so I'm not going to do anything. No, that is not there. You have to get the patient out of that critical situation to the best of your abilities and capabilities, and whatever best you can do. Another point is that at times what happens, like as a pulmonologist, you get a patient, and that patient is say of a cardiac patient, and now you need to refer that patient. You say that I'm not going to touch. Fine, you do whatever best you can. You can give the first aid as per your knowledge and as per your abilities and capabilities, and then you have to transfer the patient. Remember one thing, it is your job in at least the critical situation to transfer the patient safely to another doctor. And in a critical situation, suppose I have to refuse that, fine, I'm going on a chutti after 2 days and I have to refuse this patient, and I'm not going to take this patient. Then it is your duty per se in a critical case to ask that another doctor or one of your colleagues to take over that patient. So this right is absolute only in the OPD scenario when the patient is more or less stable. But if it's a matter of life and death, no, you have to do your duty.
So thank you, everybody. We have had a wonderful perspective on code violet. Everybody, I think we have discussed many issues. We are overshooting time and we should be closing at this time.
Dr.
And
Munje,
I know,
I
sir.
would like to say one last thing.
Yes.
As we are
As
doing,
it is, I'm going to ask one-liner to everybody.
right, exactly.
So
What we are doing at airports, if somebody is fighting with the staff, then his name is blacklisted. Somebody has started, somebody should start this thing. If anybody, any person is misbehaving with the medical staff, his Aadhaar number should be flagged somewhere so that he doesn't, please, at some point of time, we have to be little stronger and little aggressive in understanding. Somebody is misbehaving. Why he should do that? When there are no issues, why he should do that? So can we do that? And the rules and the Protection Act should go very strong. I know we have been talking that the police security is there, but it never works. I tell you, in our hospital, we ask them, are you posting some policemen? Yeah, we are trying to post few policemen who have some health issues so that they can go and talk to you also, and they will take care of the hospital also. So this is the way. So we have to be very aggressive in taking care of ourselves. Otherwise, you are going to face such problems very frequently in future. Thank you.
we are almost at the end, but before I end formally, does anybody want to add something which they feel would add to whatever we have discussed till now or summarize in one sentence? Dr. Vibhu?
Ma'am, one
Huh.
quick thing. What sir said
Yeah.
might be possible and feasible in future. That Aadhaar card, what he said, because now NMC has made it mandatory to have the Aadhaar ID of all the patients. Without that, they will not count it for the outpatient attendance as well as whatever numbers that is required for the recognition. In fact, they've been saying this over a period of time in different meetings. So I think this may become a reality. You will have the Aadhaar ID, and if you have that, you can probably go and book that person and have that repercussion that sir proposed.
डॉक्टर विभू इसके बारे में आपका ओपिनियन सब एंड में देंगे आप whether it is really doable and what does IPC say about it. Dr. Narayana, would you like to add something? A quick, fast one-liner, followed by that Indu, a one-liner.
Yeah, this is actually really burdening the healthcare system. If both the parties, like patients, also has to understand the gravity of this situation, and they also should join the hands, not alone the burden of the treating doctors. That is one thing I want to stress. Yes, Indu madam.
Yeah, I just feel my strong opinion is on the communication. I feel everything, 99% of the violent, aggressive behavior can be de-escalated by a good communication skill. So I think active listening should be inculcated in the youngsters and the young doctors, and that should be appreciated if they follow that. That can de-escalate the matter, I feel.
Thank you. And Dr. Vibhu?
Okay, so
Shahajan, do you want to add something before we go
yeah,
to
just
Lloyd's?
one point that as Dr. Animesh has said about the ABHA ID, let me be very clear. It's they're mostly for the medical colleges right now and for the big hospitals, but it's not so for the other centers. So right now it's still in a nascent stage. But remember one thing, as far as the law is concerned, remember even the rapists and the murderers do get a lawyer. You can't just say that okay, this guy was not right with the one doctor and every doctor is going to refuse. I mean, that guy has a right to get himself treated. So I think we need to, and I think none of us also are going to be that brash that all of us are going to say that okay, we are not going to treat you, and now you go out of the country and get yourself treated somewhere else. I think none of us is going to be that brash. So we have to have a humane touch to the things. And remember one thing: the court expects us to be very soft and human and goody goody types. Even if we are being beaten, that's okay. Like I remember one of the judgments which was there, I think in 2018, and the doctor said that we need security, else we won't be able to work. There was this case in Delhi, and the Delhi High Court very clearly said that if you're scared, just leave the profession. While this by any chance, I mean, something happened around 6 months later. This same judge was listening to some case, and there was this culprit who was there, some dangerous guy, and he asked for an extra security. So I mean, these kind of things happen. For a doctor, you don't need we are humans and supermans, so that has to be taken.
Dr. Shahajan?
Madam, at the end of this discussion, I should say be optimistic. Only few miscreants creating all these issues. We will all overcome all these things. Our medical profession, healthcare services has to move on. We will do that to serve the humanity.
Very nicely put, sir.
Yes. So we have had a wonderful discussion. And as Dr. Ravi started on the note that today is the Teachers' Day. And for CCI and its webinar, it's always Dr. Krishna who is behind the scene, guiding us and putting in his ideas for us to take up only if we agree to them. And even in this webinar, he was gracious enough to bring in his police superintendent friend also, who is a retired police superintendent, Mr. Jagdishan. Also, few of the questions, the important ones like movies affecting, were also his input for this webinar, which we could take forward and which has really added some knowledge domain during this discussion. And we are very thankful to the CCI family, including Dr. Narayana and Dr. Krishna, Dr. Ashish, Dr. Anil, Dr. Atri, Dr. CVK, Shivani, and Kirat, who are behind the screens and working for wonderful topics, picking up best of the panel suited to those topics so that people like me can take forward this crusade for 2 hours. But a lot of work goes on for weeks before a webinar is put up by the CCI. We conclude that in a violent situation, evacuate all persons and patients and bystanders, just like you would do when there is a fire in an institute or a building. It's very, very important to save yourself from immediate danger and with appropriate concern for the safety for all, which is now rest with the administrators of that particular hospital, be it a corporate, be it a multi-speciality, be it a government, be it a private hospital, whichever. But security of doctors is of utmost importance, and hence you have to identify code violate and act accordingly. Even the mock drills help a lot. So if a code violate situation occurs, you should immediately report the situation to the proper authorities, and before that raise an alarm, take an action, try to diffuse the situation, and be safe. Follow the orders of the healthcare providers in charge, who are your administrator at that particular point where you have been working. So before I end, if the mode and mood is violent, the code is violent. But before I end, may I add, today is not only the Teachers' Day, but a Samosa Day also. Our webinar has been crisp, like the outer crust of samosa, and the messages given were very savory, as you would taste that samosa and remember for a long. Thank you, my dear panelists, each one of you, Dr. Vibhu, Shahajan, Narayana, my own friend Indu, Dr. Bhargav, and Dr. Animesh, and of course Jagdish sir, who was with us. Thank you for being in this wonderful webinar. It has been a great learning for me, and I'm sure even the delegates and all those who have joined have enjoyed this. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Good
Thank you.
night.
You everyone.